Hi, hello everyone. Good day. Welcome to this first session of the International Society for Telemedicine and eHealth Student Contest and Award 2025. I'm Simone Farah, the coordinator of the student membership category, and it's a great pleasure to host you here today for a celebration of talent, dedication and innovation in telemedicine and digital health. I'd like to thank our jury members and our president of ISfTeH, who will be with us today. And congratulations to all students who submitted your works. Your commitment to shaping the future of healthcare is inspiring. So welcome you all. And well, it's important to inform that this session transmitted via Zoom will be recorded and then posted at the ISfTeH website. And after this first session, and based on the score provided by the jury members, 3 participants will be granted to gold, silver, and bronze medal and the prize of 600, 250, and 150 euros, respectively, in an award ceremony in September. And I would like to thank our sponsor, the Finnish Society of Telemedicine and Telehealth, for their generous support in making this initiative possible. Thank you so much. And this year, we are proud to announce that the final award session in September will take place as a pre-Congress activity of the 30th anniversary celebration of the Finnish Society of Telemedicine and eHealth. So I have the great honor of joining that moment in live in Finland, from Finland, to announce and celebrate the winners. And as we used to say, telemedicine and digital health are no longer emerging trends. They are essentials, pillars of modern, accessible, and equitable healthcare worldwide. So you, students, you are the voice of this transformation. And congratulations to be here sharing your experience in this first session. But before we move on to the presentation, let me see if Michelle is already here. Yeah, hi, Michelle.
Hello,
Hi,
how are you?
Therese. Osama, welcome.
Hi.
Good to
Hello,
see
how are you?
you. And well, I'd like to give the word to our ISfTeH president, Michelle. Please, Michelle.
Yes. Good day, everyone. On behalf of the International Society for Telemedicine eHealth, I'd like to welcome everyone to this really a significant part of the ISfTEH annual events. The students are the lifeline of the ISfTEH, and as president, I look forward to participating in this particular event annually. Student membership is free, so we encourage you to share with your colleagues the value of the society for those who are interested in learning more about digital health and how you can best go about incorporating this field into your future careers. We encourage you as students to join the society. There's so many opportunities. We now have a new website launched, and I look forward to highlighting on the website the winners of this particular competition. And I don't want to keep you much longer, but I will say that I am looking forward to the presentations after reading all the preliminary documents that were submitted. So again, welcome, and I won't take any more of your time.
Thank you very much, Michelle. And well, now let's begin with the student's presentation. Each student will have 10 minutes to present, and after the presentation, we'll have a brief moment for any comments or questions. And the first student to present is Brenda Costa from Iguaçu University from Brazil, with the work entitled Teletriage as a tool to support the indication of hospital care for patients with disabilities, an experience report. Please, Brenda.
Hi, everyone. It's a pleasure to be here with you all. I am from Iguaçu University, and I am representing a full group of friends that helped me with this project. So it's a pleasure to be here. I'm gonna share my work with you all right now. It's going, right? Well, is everyone seeing it?
Yes, perfect.
So
Good
let's get
luck.
started. Thank you. Well, guys, for starting this, I would like to say that all this work was coordinated by Ana Paula Dornelas, our professor at the university, and our work is an experience report of how teletriage can help us during the screening of patients with disabilities, and this is a very important thing for us, and I am happy to present it to you. So let's get started. Teletriage is a tool to support the indication of hospital care for patients with disabilities. Well, such as we know, patients with disabilities or multiple clinical conditions, being then physical or neurological conditions, may require special needs and special attention. And it is not different in our dental healthy care. And some of those patients can present the necessity of hospital dental care with general anesthesia. And though there's this necessity for our traditional dental healthy care, it is still a challenge for us to organize the flow of the services and the prioritization of the cases due to severity. So we are here to introduce teletriage as a very effective tool to detect priority cases and define risk scales. Well, as we all know, technology has already taken place in many sectors of our life, and it is not different in the healthy care sector. I'd like to highlight two examples that we all use all over our clinical sectors and healthy sectors, that we now use electronic medical records, so you don't have to keep a pile of papers anymore and to keep with our patients' records. And also another example is during the pandemic of COVID-19, we had increased the use of teleservice because the patients couldn't go out of their homes. So it was a very effective tool. And in the same context, the dental teletriage can prove to be converging in reducing clinical time for us as dental carers, optimizing the waiting list in hospital sectors, and determining cases according to the severity. I'd like to highlight the first point that I've mentioned, that is reducing clinical time, because our intention here is not to replace the physical exam and the clinics. It's just to remove some of the steps, like the anamnesis, that we can do that by telescreening to optimize our time and to reduce the time of these patients at our clinic, because we all know that they already have special necessities, and they can be stressful. It can be stressful for them, for their carers. So actually, our intent is to skip a step from the clinic place and put it in a technological way, so it could be more easy for us to the follow-up with the treatment. Well, diving into our project itself, the teletriage was carried out on May 2025 at University Campus 5 in Itaperuna, Rio de Janeiro, with the support of our dentistry clinic school. The students in their final year of dentistry as pre-selected. Is everyone okay seeing what I'm sorry, guys, my laptop just turned off. I don't know what's going on.
No worries, we can wait. We can see
Yeah, we
one
can
of
see
the
your
slides.
screen.
We can see the last slide.
Oh, the case
right.
report? Okay. So you can see the slide I'm on?
Yes, not the
Okay,
full
so
screen, but
It's not maximized, but we can see it.
yeah, my computer just blanked. It's all black and I'm not seeing anything. But I will keep on going with what I have.
okay.
Well, to be able to present our case report, I want to mention that this whole project was carried out at a laboratory skills, and that we have a simulated office where we can simulate the services to patients, and then we use this place to dive into the telescreening and to talk to the parents of the mostly were child. So we talked to them during the work. I'm just going to access my project with my phone for me to see because I'm not seeing anything. Let me just catch it.
I feel like computer feels our anxiety and fear
Yeah.
all the time. Don't
I
worry,
can
we've been
I
through
can
that.
try, Brenda, to share my screen. Just let me, maybe it can.
I don't think it's gonna work. I guess the problem is my computer, it just blanked. It's all
Yes.
black.
Can you see my screen?
No, I can't see anything. It's like black,
Let,
real.
okay, but as you present, I will, can you see my screen? Everyone, not you, Brenda, but
Yes, we can.
Michelle, yes?
Yes, we
Okay,
can
so,
see.
so don't worry, I have your presentation here. So as you talk about it, I can share it here, no problem.
Okay, so in the case report slide, there's a image of a guy sitting on a chair with a table with computer, and this is actually the place we did the telescreening project. Moving for the next slide, I have a step-by-step what we have done during the project. Well, we pre-selected 66 clinical records for us to make contact with, but unfortunately, due to many reasons, just 27 of these clinical records were found by the phone number on WhatsApp. So we've been in touch with them, offering a free telescreening service to see if the children needed anything or if there was something going on with them that they were not able to attend to the clinic. So we could talk to them first. And we have scheduled the appointments with the patients to 13 o'clock on May 27, sorry. And from these patients, just 6 of them attended to the video call. We have done it by Google Meet. It was an encrypted meeting, so we didn't have the intent to share any information. It was just an interview. We didn't record, we didn't register it, we didn't share this information of the meeting. So we have established a risk protocol for those patients and the analysis of feasibility for outpatient care for those. Well, as a result of this work, we have classified 6 patients and divided them in 3 groups: low, moderated, and high risk. So we have classified 3 of them as low risk, 2 of these patients as moderated risk, and 1 of these patients in high risk. Well, what we have used to determine this scale of risk, we have used the medical story, the systemic conditions of these patients that could influence on their dental care or anything like diagnosis or treatment. The main complaint, if they have some sort of pain or if they were with some symptoms or infection or inflammation, something like that. The patient's compliance level, we are talking about patients with disabilities, and some of them were not compliable. So it was already a sign for us to refer for them to a hospital care under general anesthesia in case of tooth extraction or surgery. And we have used it as a basic factor, the oral hygiene habits of these patients too. And we classified these patients based on those informations. Well, as you all saw, the small sample that we got, despite the small sample, we highlighted that the teledentistry can be a very effective tool on determination clinical and administrative decisions. We can help to divide the sectors and to determine if the patient was an elective patient or an emergency patient, or if they were in a several case and we needed to refer him straight to the hospital care. And we truly believe that these early identifications of emergency can reduce stress and negative impacts for these patients. And I wanted to highlight that more than us, these patients already face things that we will never know about. So they already face challenges in life. So our intention was to reduce it. And as we reduce the negative impacts, we reduce the stress of these patients, of these carers, and we can offer to them more quality of life or more healthy. Well, in the results slide, I just would like to highlight 2 of our patients. One patient we have classified as a moderated risk, and he attended to the clinic. He was a very special boy. He had neurological paralysis, and he needed a periodontal treatment. And we've been in touch with the mother, and she got flattered by the fact that we were going to serve this patient there. And he went, and as you can see, it's the whole team of the research. And Blue, it's our coordinator professor. And it was a very successful time. The therapy went well. He was a very collaborative person, and we felt very happy for that. And the last one, I would like to highlight the high-risk patient. He had a need of teeth extraction, but he was not collaborative. So we talked about that with his mother, and we told her that he needed to be under general anesthesia to be treated, and we started to referring him to hospital care. To finish it all, guys, the conclusion is that we believe that teletriage that demonstrated a very high potential and very effective to identify dental emergencies in patients with disabilities, knowing that these patients had already some sort of difficulties to reach us in the traditional dental care system. So we truly believe that projects like this can strengthen care networks and reduce inequalities in the access to healthy care, specialized healthy care, that is still unfortunately a reality for us in Brazil. I am delighted for the opportunity to show my work, despite the problem that I got, but I cannot see any of you guys right now, but I hope you guys understood what we are here to stand for And we are from a small town, and we're a small group of people, but we are very happy to get it started our university. We are actually the first students from our university to participate of it, and we are very, very happy for that. I thank you guys for the opportunity, and that's all.
Thank you very much, Brenda. Congratulations. And this is the first teledentistry work presented in the last 4 years. So
Wow.
very, very good. Excellent. Congratulations to you and to the other students and to your professor. Well done.
Thank you.
And now I'd like to now our next student, sorry, is Júlia Nascimento da Silva Mulder from University of Coimbra, Portugal, and also University of São Paulo, Brazil, to present your work entitled The Digital Education Paradigm in Dental Teaching and Learning. So another experience in teledentistry. Welcome, Júlia.
Thank you very much, guys. I appreciate the opportunity. Can you see my screen?
Yes, perfect.
Perfect. So you can interrupt me anytime. So, hi guys, my name is Júlia. Good morning, everyone. I'm going to talk about the digital education paradigm in dental teaching and learning. So I do know the professor from Brenda. She's also from my team. So maybe that's why we're talking about teledentistry. So it is amazing to hear your experience as well. So today I'll be more focused in the educational part, but we also had teletriage, and it is a pleasure to see all the applications that we got. So, okay. So nowadays we live in a hyper-connected reality where we cannot separate real from digital anymore. And we need to have the educational models and strategy appropriately aligned to that hyper-connected reality. So we want nowadays to use digital technologies to create critical consciousness within our students. And what is the key point in this whole scenario? It's still communication. So if we want to integrate physical and digital spaces, and if we consider this change of time and space relationship that we have nowadays, we need to focus on the communication part between teachers, students, patients, etc. So we can have these new ecosystemic interactions, and we need to put this interaction and participation within the pedagogical relationship. So I am part of the Telehealth and Teledentistry Center from the University of São Paulo. And last year I was for a semester in Coimbra, and we've been studying what are the tools that we have right now in the modern dental education. So we want to understand the hybrid reality as a driver of this new educational landscape. We want to understand which ones are the educational practices enriched with digital tools in the teaching learning process of all health professionals, but mostly how is this digital education network applied to dentistry regarding the applicability and paradigm shifts. So we have hybridism, this mix of traditional and digital learning, as an opportunity to expand opportunities for collaborative knowledge construction between students and teachers. So we can use blended learning or hybridism for the capacitation, experimentation, and reflection, the development of abilities, and the comprehension and assimilation of content. So we can apply this blended teaching and learning to training and care flows. So for patient monitoring, for 3D image processing, for surgical training and simulation, virtual therapies, development of less invasive surgeries, etc., but also for educational applications. So we have virtual labs, libraries, remote meetings, all the arms of e-learning, so for training, communication, interaction, and of course, for the development of clinical skills. We have that summed up with the opportunity of self-instructional learning. And this leads usually to a high satisfaction among students, mostly because of the flexibility and autonomy given by the hybrid education propositions. So we know that realism and precision are essential for the healthcare field. So for all the healthcare field professions, we need to understand that the student is now within the narrative. So we can use augmented reality or virtual reality for sustained intervention, but this will always depend on pedagogical planning. So for augmented reality, you will have an object and virtual object, but within an unusual scenario. And for virtual reality, we have full immersion. In a way or the other, for dental education, we have the strategies that are aimed at the acquisition of theoretical knowledge. So the platforms that allow the student to access the content. The ones aimed at the acquisition of clinical and preclinical abilities, so mostly simulators. The ones aimed at patient care and decision-making, so teleconference platforms and apps, etc. The ones aimed at training and summative evaluation, so even Google Forms could go inside this category, and the ones aimed at information sharing. But regardless of the virtual training that we choose, we need to focus on a graphic system that values the realism of objects, the spatial correlation between objects, the interaction between human and robots, precision, and the responsiveness of algorithms. So you can imagine if you have a simulator and you're doing the preparation, a cavity preparation, you need to have an algorithm with a proper response to texture, to pressure, to everything. Otherwise, this student won't be properly trained. So it is essential that these algorithms are very, very well trained. And to have this automatic evaluation performance, we need to stipulate what the ideal performance is. So for machine learning and to train this these tools, we need to have professionals involved because we need to stipulate the ideal performance. So right now we have two major lines happening in dental teaching. So we have haptic simulators that simulate realistic perspectives and that are sensitive to the educational approach using both AR or VR. So they simulate situations compatible with the clinical practice, and they're mostly focused on the development of motor skills in preclinical and training. So they make it possible for the students to focus on knowledge retention and transfer in various specialties, and also for the stratification of students in their clinical performances. So we go for an individualized training. And this is very good because you respect the learning pace of each and every student, and you can provide greater assistance and support from tutors. So if you have a student that is struggling very much with this one particular exercise, he can do it again and again and again, and having better support until he becomes satisfied and he learns properly. So this leads to increased autonomy and satisfaction rates. For neural systems that mimic the human brain to simulate human cognitive abilities from problem solving to learning and decision making, we have in different areas of dentistry different applications. So for radiology, you can have a facilitation of diagnosis, treatment plans, prediction of results. For restorative dentistry, you can have cavity detection, verification of restorations, planning of preparation, and even prediction of bacterial colonies. So for endodontics, you can have detection of lesions and foramen and anatomy, image analysis, cephalometric analysis, and therapeutic outcomes. For surgeries, you can have surgical planning, prediction of postoperative complications, detection of lesions as well. And for periodontics, you can predict periodontitis or assess bone loss. So we have too many applications right now happening with the use of this hybridism. So to have an efficient learning process, you need to focus on pedagogical methodology. So we have to understand the resources and the functionalities of each media to understand which one is the preferred, the suited one for the preferred methodology. And so we need to focus on a pedagogical design that prioritizes the experience without putting anyone or anything at risk, or if it's extremely expensive or unaffordable. So we need to understand what the conditions are. And this could benefit from both AR or VR. So we can focus on the idea that the student's learning curve can always be improved. And hybridism and blended learning will help in this learning curve with this proposition of individualization of teaching and learning, with the possibility of having structure or teacher available to help these students, and to have this educational environment enhanced with media and training. So we understand learning as a social experience where we have interaction through language and action. So in this learning process, we have cooperation, autonomy, individual centrality, and we use the concepts of interactionism and constructivism to build this collective search for problem solving in the development of individual doubts and certainties. So you take an insecurity that's individual and you look for collective solutions. So we need to understand this range of possibilities of ICT in health and dentistry, and we need to align teaching with this digitalization of modern coexistence that we already live in. So we need to break with traditionalism. We need to recognize educational gaps and particularities. And so we can see hybridization as a strategy for promoting health and to redefine the educational paradigm. So we must understand that, like, Mom, this is not a phase, but an essential strategy to assure that graduates are fully competent and up to date, because the students will be the healthcare field of tomorrow. So we need to make sure that they are properly trained and aligned with the digital reality that we live nowadays. So thank you very much, and I'm open to any questions. Thank you very much.
Very, very good, Júlia. Thank you. Congratulations to you and to all the team involved in this excellent work. Well done. And well, now I'd like to invite the third student to present is Júlia Silveira from Iguaçu University, Brazil. Reconnecting to care, experience of dental students in screening dental emergency in patients with disabilities. Please, Júlia.
Hi guys, it's a pleasure to be here. Can everybody see my screen?
Yes, perfect.
My name is Júlia Silveira. I'm going to present a project development by 5 undergraduate students. And this project was supervised by the professor Ana Paula Dornelas. She's a great professor. And today I'm going to show you our teaching methods at the university and how the teledentistry can improve the contact between patients and health professionals. The title is Reconnecting to Care, Experience of Dental Students in Screening Dental Emergencies in Patients with Disabilities. Introduction. It's a universal extension project of a real-world practice scenarios that enhance student education, especially when they involve emergency technology such as teledentistry, as I said. And what was the objective? With the teledentistry, we have opportunity to treat patients at any time, is managing patients with disabilities, and university student service experience with modern, safe, and fast service. What was the methods that we used? This is an experience report development at Iguaçu University Campus 5 between April and May 2025. 66 medical records of previously treated patients with disabilities were selected, but only 27 caregivers were contacted via message app. We used WhatsApp message to talk with these patients. Only 7 responded, enabling the telescreening to be carried out. The activity was conducted by 5 final year undergraduate students under faculty supervision. The remote interview followed a guide protocol for assessing urgencies and risks. We select the patients and we take care to classify the risk and the urgency of the patients. Here, I will show you the research laboratories that we have at the universities, and I bring 2 videos to show you. In the first, it shows how the professor can observe the students. The students are each one in the private rooms, and they are developing telescreening. The professor can walk between the labs, and the professor can see all and listen all the things, but the student can hear and can see the professor. All the professor wants, the student can hear what they want to say. It's supervised sorry, a little bit nervous. Laboratories with free access for the teacher to the student conduct. On the second one video, we have a student doing his telescreen. The intervention and the contact. The teleconsultation was carried out in the skills laboratories on the observation and guidance of the supervising teacher. Contact was made with those responsible via WhatsApp, schedule a date for the teleconsultation which had a risk classification, assess the need for outpatient or hospital care. According to the risk, we evaluate the patient for a hospital care or an outpatient. Clinical conduct. After the teletrace, a meeting was held between the students and the supervised teacher to discuss the clinical case and the individualized clinical conduct. Here I have 2 images. The first one is a student, and the second one is the teacher observing and conducting our procedure. Clinically, oral hygiene instruction was provided to the responsible caregivers, and supragingival and subgingival periodontal scaling was performed. The entire process was supervised by the supervising professor, as I said. He is a special guy. Discussion and social relevance. The activity allowed the student to develop clinical and communication skill in a virtual context, sparking reflections on accessibility, treatment, abandonment, and humanized care. The active research found students the importance of bonding, qualified listen, and ethical approach when conducting their remote screenings, especially with families of patients with disabilities. Results. What we could learn with that? Students report challenges such as low adherence to remote contact and the need to adapt clinical language to get used listening skills. However, they highlight the experience as enriching because it brought them closer to the reality of digital health, expanding their critical and empathic vision. In the extension proved to be effective as an integrative strategy between teaching, service, and community. With this project, we could approve our empathetic vision, listening skills, clinical language. Conclusion. The experience with teletraging patients with disabilities who were away from the clinic proved to be a powerful learning field for dentistry students. In addition to the social contribution for the activity favored training in digital health, promoting skill for working in vulnerable contexts and transforming clinical practice into a pedagogical opportunity. So my vision about the telescreening is the best way that we have now and in the future to treat patients with fast, care, safe, and care health. Here I have the reference. I want to thank you a lot for my presentation. It's a pleasure to be here with you, and I'm open to questions.
Thank you, Júlia, very much. Congratulations, well done. And our next student to present is Laura Carrara Ribeiro from Federal University of Viçosa, Brazil, with the work Physical Activity Counseling for People with Hypertension, Diabetes, with motivational phone calls and a WhatsApp channel. Good luck, Laura.
Hello, everybody. It's such a pleasure to be here. I'm gonna share my screen now. Not in the full, right? You all can see the presentation.
Yes, no, it's okay.
Let me. Okay. So hello, everyone. My name is Laura. I'm a medical student at Federal University of Viçosa, and today I'm pleased to present our work called Physical Activity Counseling for People with Hypertension or Diabetes via motivational phone calls and a WhatsApp channel. This project was developed in a partnership with the Federal University of Jequitinhonha and Mucuri's Valley, the Telehealth Center of Federal University of Minas Gerais, and the Project Charming. So first of all, it is known that physical activity protects against hypertension and diabetes by decreasing blood pressure and reducing insulin resistance. To guide the behavior change, we use the trans-theoretical model, which is an effective theory for individuals who still feel uncertain about initiating some healthy lifestyles. This theory is based on 5 stages of change. In pre-contemplation, the person doesn't see a problem or isn't thinking about changing. In contemplation, they start to realize there is a problem and think about changing, but haven't made a decision yet. In preparation, they decide to make a change and start planning how to do it. in action, the person actually starts changing their behavior, and in maintenance, they keep the new habits over time. The goal of our project is to promote physical activity by using motivational phone calls and WhatsApp channel with short educational videos. So the Charming project is a multidisciplinary initiative operating in 5 low infrastructure municipalities in Minas Gerais, which aims to improve the health of people with hypertension and diabetes. So we classified the Charming project participants in stages of change for physical activity according to the trans-theoretical model, and we delivered stage-tailored motivational messages for them during phone calls. We also developed scripts for short videos promoting a healthy lifestyle for a WhatsApp channel. Here you can see the channel we created called Projeto Charme. This is the algorithm we use to classify the participants according to the stages of change. But we asked simple questions about their current physical activity and then their intentions for adopting this habit. So first we asked, do you currently engage in physical activity? If they said no, we asked, do you intend to start engaging in physical activity in the next 6 months? If they said no, they were in pre-contemplation. If yes, we asked if they intended to start engaging in physical activity in the next 30 days. If they said no, they were in contemplation. If yes, they were in preparation. But if the participant was already engaged in physical activity, we asked how long they have been engaging in the activity. If it was up to 6 months, they were in action, and if it was 6 months or over, they were in maintenance. So we contacted 1,167 Charming project participants, and among them, 623 were from the intervention group and received those motivational phone calls. Among those from the intervention group, 132 signed up for the WhatsApp channel. We developed 39 short videos, and the adherence to the channel ranged from 12% to 30.4% across municipalities. Now, coming up to the discussions, the phone calls we gave allowed personalized communication and stage-tailored health counseling. The WhatsApp channel expanded access to health education in a simple and accessible way. However, the adherence to the channel varied across locations, suggesting that some barriers may have limited the participant engagement. And now to finish, we found out that the combination between human interaction like in those phone calls and some digital tools like the WhatsApp channel can be such a powerful strategy for future health education. We also found out that the motivational discourse really matters because it can trigger behavior change in patients living with hypertension and diabetes. This research also pushes us to think about some new and creative strategies to promote physical activity, especially in the rural areas, where the sedentary behavior is such a major issue and studies are still very limited. So this study not only supports the use of a hybrid model, but also opens up important questions for future research and practice in rural health promotion. And that's it. That's the references we used for our work. And if you have any questions or comments, please let me know. Thank you very much.
Thank you, Laura. Very good. As a cardiologist, I may say that's something very important for hypertension diabetes patients to motivate them to change their habits. So very good, well done.
Thank you.
Now I'd like to invite Maria Tavares da Rosa from Rio de Janeiro State University, Brazil, to present two works. The first one is 3D printing as action research for health education and digital law in medical education, and report on the experience of the academic league of finance and entrepreneurship in medicine. And sorry, Maria. The 3D printing as action research for health education and digital law in medical education, a report of the experience of the academic league of finance and entrepreneurship in medicine. Good luck, Maria.
Hi, everyone.
Hello.
Thank you, Simone. Are you seeing my screen?
Yes.
Okay. So, good morning, esteemed judges, colleagues, and guests. My name is Maria. I am a medical student of the 5th year from Rio de Janeiro State University from a total of 6 years. And today I'm honored to represent the Academic League of Finance and Entrepreneurship in Medicine, the LAFEN League from Rio de Janeiro State University, UERJ. Today, I invite you into an involving frontier where medicine meets law, an area increasingly essential yet often overlooked in medical education. In this presentation, I invite you to explore how digital law is becoming a new chapter in medical education. We'll begin by contextualizing our Brazilian scenario. Then I'll introduce LAFEN's intervention and how we created an interdisciplinary space between medicine and law. We'll look at the educational impact of this initiative, the outcomes observed among students, and finally, we'll conclude with key takeaways and future perspectives for this innovative approach. In most medical schools in Brazil, there is a critical void: the amount of theoretic and unpractical subjects and a lack of training in real-life medical responsibilities, such as health digital law. Despite telemedicine being regulated by the Federal Council of Medicine in Brazil, the CFM, since 2003, and updated and complemented in 2022, including eHealth. As digital health platforms grow as a matter of projecting yourself and your work into the market, which is overloaded, doctors must navigate complex legal ethical landscapes, often unprepared. Recognizing this, we designed an innovative educational initiative through our academic league, LAFEN, to complement traditional curricula and to prepare future doctors about the use of digital technologies on medical practice. We created interdisciplinary sessions through lunch breaks in 2023 and 2024, combining legal and medical perspectives. Picture this: a physician specialized on telemedicine and eHealth, a legal expert on medical law, and medical students in open discussion. We approached the groundbreaking resolution from CFM number 2336 from 2023, which redefined the use of before and after images in medical advertising, which was restricted so far only for nutritionists. The subsequent debate expanded the discussion beyond the new aspect of medical marketing, highlighting civil implications related to patient privacy violations. For example, if a physician reposts an image originally shared by the patient on a private network into a public profile, it could trigger a legal confrontation based on violations of patients' constitutional rights, such as privacy. But our goal was bigger than interpretation. We aimed for the transformation. One of our most impactful sessions tackled how poor documentation can lead to devastating legal outcomes, not just for doctors, but for the patients we vow to protect. We discussed medical error and the patient concern form, focusing on the documentation required to legally validate the patient's understanding of procedures, side effects, medication use, and bodily repercussions. The aim is to prevent legal disputes due to lack of informative records and to ensure proper documentation of what was explained during consultations. The lawyer gave a real example she witnessed at the time about a woman who has been through a hysterectomy, and years later she comes back at the same doctor with a complaint about not being able to get pregnant and the lack of knowledge that she needed her uterus for this. The consent form emerges as an ethic and legal strategy to prevent conflict if the patient and the doctor have the same goal, to provide care and use the best options available for this. Through these debates, students began to see law not as a threat as the media makes us feel, but as a tool of knowledge expansion to be incorporated on medical practice to combine better care and legal support, and to create awareness of the legal repercussions of the law into medical practice, beyond its contribution to the patient understanding and reducing legal vulnerabilities. The tension between medicine and law became synergy. It was no longer a clash, it was a collaboration. And starting this shift in a mindset was our biggest victory. The outcomes of this project have gone beyond the classroom, sparking institutional and academic interest. The discussions and findings from the LaFame sessions were selected at scientific events, including academic exposition in 2024 at UERJ, the UERJ Sem Muros event, the University Hospital Congress, the Congresso UP 2024, and the Academic League Exposition in 2023. These opportunities allowed us to share our experience with a broader academic audience and validate the relevance of digital law educating in medical training. Additionally, student engagement was continued to grow, showing that future healthcare professionals recognize the value of legal knowledge for ethical and responsible digital conduct. The initiative not only fostered critical thinking, but also positioned students as active agents in shaping a more legally aware and prepared medical community. In conclusion, through LaFame's interdisciplinary sessions, students gained critical awareness of the legal implications of medical advertising, patient privacy, and documentation, topics often overlooked in traditional curricula. By fostering a space where medicine and law intersect, we empowered students to act more consciously, confidently, and responsibly in both clinical and digital environments. We are not just learning medicine, we are shaping a safer, ethically grounded medical practice. Teaching digital law doesn't just prevent lawsuits, it protects lives. Thank you.
Thank you, Maria. Very good. And now you can share your second presentation, please.
Okay. It is showing, right?
Right.
Okay. So just a moment to... Okay. So hello again. In the second initiative, I wanted to show you how technology can do more than diagnose. It can educate, empower, and inspire. At Janeiro State University, we have been using 3D printing to revolutionize how young people understand their bodies. First, I'm going to present the challenge and goals of the project. Then, the development of the methods and innovation, followed by its results and educational impacts. At last, the conclusions that were made and our future perspectives. As you picture yourself as a teenager growing up and starting to feel a lot of changes in your appearance, mood, will, and thoughts, you probably remember that it was a tough period to gather those pieces of information together to build your own character. Generations change, but this feeling still continues to be a temporal and universal. In addition to the whole changing and confusing scenario, Biological processes such as menstruation, fertility, and reproductive function are surrounded by stigma about the knowledge of its own body functions and potentials. To complement that, traditional teaching methods, which rely on textbooks and static diagrams, frequently fail to convey the complexity and relevance of these topics in a way that resonates with young learners' interests. As a result, many adolescents lack the basic knowledge necessary for informed self-care and reproductive health decisions. By transforming medical imaging into tangible and anatomically accurate 3D printing models of the feminine reproductive system, we offer a powerful interactive educational tool that enhances understanding, promotes body awareness, and helps dismantle taboos around our reproductive health. Our project brings anatomy to life, literally using 3D printing. We began by sourcing models of the feminine reproductive system in public databases, in which we found this one at ThinkVerse website that shows anatomically the uterus, ovaries, fallopian tubes, cervix, and vaginal canal. We aim to create a consolidated perspective of these abstract concepts that are only seen in books or videos in biology classes, including a new aspect on their comprehension, its size and depth. The model was printed using an Ender 3 V2 printer with PLA filament and lilac with 1.75 millimeters diameter and layers with 0.18 millimeters. The process took 6 hours and 6 minutes to be completed. We hosted discussions at the Adolescent Health Studies Center, NESA, at Federal University Hospital in Rio de Janeiro waiting room for teenagers, mainly 13 and 14 years old, and their parents, starting with a short presentation about general aspects of the menstrual cycle and physiologic processes such as menstruation and pregnancy. We provided a Q&A formulary before and after the explanation to assess patients' comprehension and reasoning elaboration, after mentally integrating the theoretic aspects and the anatomical model. In the following, some of the questions and answers are presented. We asked, what is the uterus for? And the answers before were, where the man's sperm stays and to shelter the baby. What is menstruation? The period when woman releases blood that should go to the baby, fertility period in woman, and when the oocyte isn't fertilized. And at last, how women get pregnant, when man releases the spermatozoids and sexual dilation. So beyond getting the answers right after the explanation, the most impactful results of the discussion was that before the questions, the teenagers were shy and introspective, but after showing them the model and letting them touch it, they started to complement the information I gave earlier with a few questions, like women menstruate forever and they don't get anemic after menstruation. And I was able to deepen the explanations using the anatomic model to introduce themes such as menopause. By integrating these models into adolescent education, we helped students visualize and understand the menstrual cycle and reproductive function. In conclusion, our 3D printing initiative has proven to be far more than a technical innovation. It is a transformative educational tool. By offering anatomically accurate and tangible models of the female reproductive system, we have significantly improved adolescents' understanding of complex biological processes such as menstruation, fertility, and pregnancy. More importantly, the project contributes to the destigmatization of reproductive health by creating safe and engaging spaces for discussion, replacing embarrassment and misinformation with clarity and confidence. These interventions help young women develop a healthier relationship with their own bodies and young boys to understand what happens with their mothers, sisters, and future partners. As a result, we are not only fostering scientific literacy, but also promoting youth empowerment through accessible, inclusive health education. Ultimately, this project demonstrates how simple and fast interdisciplinary strategies can break down barriers in health education, equipping the next generation with the knowledge they need to make informed, respectful, and responsible choices about their health. At the moment, we are working on 3D segmentation using fully anonymized imaging data from CT and MRI scans from the teenage patients of the Pedro University Hospital in Rio de Janeiro, indicated for other clinical conditions, in order to transform this into anatomically accurate 3D models and compare it with the one designed previously, aiming to make it available on a public database to contribute for the society as the first one contributed to us. This project aligns with Brazil's general data protection law, proving that innovation and privacy can coexist. And while our focus began with adolescent health, the potential for medical education is limitless, thanks to pouring disease explanations like lung cancer related to smoking effects, alcohol's impacts on liver's anatomy, and even being able to explore a cell structure. When students see and touch a 3D uterus, the human body stops being theoretical. It becomes real. Through 3D printing, we've bridged the gap between abstract science and tangible understanding. And doing so, we've planted the seeds for the generation of informed and empowered individuals. Thank you so much.
Thank you, Maria. Congratulations. Well done. And now I'd like to invite Pedro Luiz Gouveia from Rio de Janeiro State University, Brazil, to present the work entitled 3D Printed Anatomical Models of Abdominal Aortic Aneurysm. Welcome, Pedro.
Hello. I will
Hi.
share my screen right now. Okay, can you see it?
Yes.
So great. So first of all, my name is Pedro. I am a medical student from the Rio de Janeiro State University 2, UERJ, in Brazil. And I'm also a research student in the field of telemedicine and telehealth, under the supervision of the Professor Alexandre Monteiro. I would like, first of all, to thank you all for the space. And I'm here to present the 3D printed anatomical models of abdominal aortic aneurysm. So I would like to do a short introduction talking about what is 3D printing, the methods behind it, and what is aortic aneurysm properly. So 3D printing, I know it's not a new technology, but I think it would be a good idea to talk and how we do it to everyone in this meeting have the knowledge of the work behind every piece. So 3D printing is basically a form of additive manufacturing. And what is this? Is when we do multiple layers. So we overlap layers by layers over a platform to finally build three-dimensional models that it was originally a virtual model. We have different methods to do it, and I listed basically the two most used worldwide, and the two we actually have in our lab. The fused deposit modeling, or FDM, that is basically a filament made of plastic that is melted and extruded by a nozzle over a mobile platform. And layer by layer, they solidify to form the model itself. And stereolithography, when we use a liquid resin that solidify using infrared radiation. Each method has his own characteristic advantage, and we basically choose between them, thinking about what we want to have as the final result, about it transparent, flexible, or solid, about the texture, and thinking about that, what is the purpose of the model we choose between these two methods. And finally, the aortic aneurysm. I put a picture in the slide before this one, and is characterized basically as the dilatation over 50% of the original diameter of a blood vessel. The aortic aneurysm can occur in any blood vessel, but mostly it happens in the abdominal portion of the aorta. It is a high-risk pathology with a high mortality risk, and usually we need to pass through, and the patient has to underwent a surgical procedure to correct it. Normally, we do open surgery, but in specialized centers in Brazil, we are able to do via endovascular procedure, where we basically put a graft inside the vessel. Here in Brazil, our hospital, Pedro National University Hospital, is a reference center for this type of pathology. Here, I basically put a video of in our lab, made in our lab, to show you basically what is the technology that I already told you. We have a mobile platform and a nozzle that basically puts the melted plastic layer by layer until it solidifies into a fine piece. So now I want to talk about the methods behind it, how each piece is made, what is the work that is intrinsic of every piece, and the process behind it. Saúde 3D, that basically means 3D health, is the name of the lab that we have in the Pedro National University Hospital. It is a lab to do three-dimensional modeling and three-dimensional printing, and he's nearby at the hospital, and we basically help in the clinical and surgical demands of the hospital. We have nowadays like 9 printers, 4 of them for resin, for stereolithography, as I said before. And for me, it's a really, how can I say that? It's a really emotional topic. When I think about innovation in healthcare, I am a student from a public university, and sometimes it's the first time we do something like that in the context of the healthcare system in Brazil. So it represents actually the humanization of the treatment and the personalizing care we can offer to the patient, even in the public health system. So when we think about the process, we have basically 4 topics. Accessation, where it's basically how we acquire the image to do the printing. Using basically medical image exams like TC, MRI. So we take the image and we work over it. After acquisition, we do the segmentation that basically we select the ROI. ROI means basically region of interest. So we take the TC, angio TC, MRI, and select the region that we want to print. This is the topic when we take the original DICOM file, that is the type of file that all medical exams exist. So we take the DICOM file and convert to FDL file. That is the file format that we are able to properly print. After that, we basically take the model, the virtual model, and do the modeling. That is like clear the original model, erase some imperfections, and wait to print. And the last one is the slicing that I will talk properly in the next slide. Here we have another video of one of the patients that I will talk with you, and the abdominal aortic aneurysm. This image was already treated, so we took the angio TC and this the segmentation. And all you are seeing right now is the ROI, the region of interest. Basically, the vascular surgical team of Pedro Ernesto asked our lab to help with two challenging cases of patients with huge abdominal aortic aneurysms, and they asked us if we could print the models to better understand the cases before the surgery. This image is at the Lysing Ultimator Cura. That is a program that you use to do the slicing. The slicing is the last topic that I said to you before. It's basically when we choose and we set the how the printed will occur. For example, how is the thin layer, how is the temperature of the extruder, how fast we want to it happen, and the texture that you use it, and the architecture behind or inside each piece. So it's a pretty important topic and step to the printing itself. So the results, basically, I will talk about the anatomical models and the impact that it has to each patient. So you can see the two models that we printed. The left one was the previous image that you saw, and it represents an aortic aneurysm above the renal arteries. The surgical team used both of them previous the surgical as to better understanding the case. The first one, we received a really good feedback from the teams. Actually, the most important of them was the first case that you can is the case of the left one. The surgical team was not so sure how they would do the surgery actually, if open surgery traditionally or via endovascular surgery. When we study aortic aneurysm, when we want to do an endovascular surgery, we have to be sure about the angles and the architecture of the aneurysm because we have to be able to implement the draft. And they asked us for the models because they were not so sure when only studying the image from the TC. So basically the model helped them to decide which surgery they would choose. The model was also used for undergraduate students in pedagogic classes. Here you can see the intraoperative photo of the first patient. And the middle one, the girl, the middle one named Yasmin, is probably the main one involved in the project right now. She participates also in the surgery. The team, not only the team, but the patient was pretty happy with the help the lab could give to them. So that's it. I would like to thank you again, the ISfTeH, for the space that you give me, and I open for any eventual questions. Thank you.
Thank you, Pedro. Well done. Thank you. And now I'm glad to invite Rafaela Bonfioli Costa from Federal University of Minas Gerais, Brazil, to present her work, development of a decision support system of management of patients with cardiovascular disease and indication of oral anticoagulants. Please, Rafaela.
Hi, everyone. I'm going to share my screen.
Hi.
Just 1 second.
Okay.
Did it work?
Not full screen yet. It's perfect. That's perfect. Thank you.
Yeah. Okay. So, good morning, everyone. My name is Rafaela Bonfioli Costa. I'm a second-year medical student at the Universidade Federal de Minas Gerais, Brazil. And today I will present our project on the topic of telemedicine and oral anticoagulation therapy, in a study titled Development of a Decision Support System for Management of Patients with Cardiovascular Diseases and Indication for Oral Anticoagulants. I would like to start with a brief introduction that helps to explain the relevance of our project. Nowadays, stroke is one of the main causes for death and disability worldwide. And one of the main risk factors for these events is atrial fibrillation, which is the most common sustained cardiac arrhythmia in the world and it's responsible for causing 1 in every 5 cases of stroke. Luckily, there is an effective way to treat these patients and to prevent these events from happening: the use of oral anticoagulation treatment. However, considering the difficult nature of oral anticoagulation treatment, which requires constant monitoring, a scenario many healthcare workers fear its management. And this scenario, unfortunately, prevents the events from, like stroke, from being prevented before happening. So, in scenarios like this one, the use of clinical decision support systems can be very useful. These systems facilitate doctor-patient interactions, in which the healthcare professional is able to input the patient's clinical data into the software, for example, like medications they're currently using. Through this, decision support messages are generated to help with their treatment decisions. Considering the potential of these systems in promoting more effective treatment management, our project has a goal to develop and implement a decision support system focused on primary care to manage patients on oral anticoagulation therapy. This project is being developed mainly by the Telehealth Center of Minas Gerais, which is associated to the University Hospital of Universidade Federal de Minas Gerais, Brazil. Regarding our methods, our study is a mixed method study with 6 phases. The first phase was the development of the system, which is already completed. On the right, you can see a preview of the consultation page, on which the patient's information, such as test results, are added. The boxes in blue represent the decision support messages that appear to the healthcare worker in the moment of the consultation, such as advise the patients to avoid alcohol intake and advise the patient to keep the intake of vitamin K sources constant with no fluctuations, both factors which can influence their anticoagulation outcomes. The green arrow is pointed to the result of a frequent test made in patients who are taking oral anticoagulation, which is the prothrombin test. The second phase was the internal validation, where conditional tests were performed to ensure that the system was working as planned. The third step, which is the one currently taking place, is the software implementation in 4 primary care units in the city of Divinópolis, which is a medium-sized city in the state of Minas Gerais, Brazil. These primary care units were chosen randomly and will be essential to test the system and to provide feedback afterwards, which leads us to the 4th phase of the project, which includes the evaluation of the system's usability through the application of semi-structured questionnaires to the healthcare workers who made use of the system. Following that, phase 5 will consist of software adjustments according to the feedback obtained, and the implementation of these improvements to the software's usability. Finally, in phase 6, a post-implementation evaluation will be made in order to assess the number of eligible patients in oral anticoagulation and the management of their care. Regarding our results, they are still preliminary, since the software is still in its implementation phase, with the evaluation being scheduled for June 2025, which is this month. It is important to point out that the testing of the software, performed in part by medical undergraduate students such as myself, was of great importance to the development of a reliable and efficient decision support system. Some results that we expect from this project are, first, to increase patient safety when using oral anticoagulation and to optimize healthcare professionals' decisions when doing this care. This leads us to our next expected result, which is to reduce cardioembolic events, which are common adverse effects of anticoagulation, and also abnormal blood aggregation, which can be caused by anticoagulation therapy. And finally, the implementation of our system could also reduce the cost for the Brazilian Unified Health System, which is the public system that provides universal health care to all Brazilians. In conclusion, our decision support system could be of great value, especially if implemented in primary care settings, since it has the potential not only to increase quality of care by supporting healthcare workers in patient management, but also by its ability to integrate patients' clinical data, such as routine monitoring and laboratory tests, making the management of their anticoagulation therapy easier and really more precise. I would like to thank the jury as well as all the colleagues and friends present here for your attention and for the opportunity to take part in the International Society for Telemedicine and eHealth 2025 Student Contest Award. My contact information is on the slide if you have any further questions. And thank you again for your attention.
Thank you very much, Rafaela. Thank you all. I'm very, very proud of all of you, author and also co-authors, students. Congratulations also to the professors who were the conductors leading you in your works. Well done, very good. And now I'd like to give the word to our jury members for comments and questions. Please, Cherise, are you listening to us? Michelle would like to say some words. I think Michelle has to leave to another meeting. Please, Michelle.
Yes, excellent. Can you hear me? I'm sure you can hear me clearly, right?
Yes.
Yes, excellent presentations. Yeah, I was very excited to see a new area in dental medicine. I was quite surprised that we had a number of presentations in that arena. So actually that's a positive because we're expanding, hopefully, our reach when it comes to the understanding of what digital health is, what it incorporates, and how far-reaching it is. And this is a very interesting time in terms of medicine and the transition and when we talk about the implementation of digital health. And I noticed in a few presentations the understanding that the hybrid model seems to be the ideal approach. You hear some people tout the complete replacement of the human involvement and the human interaction. And I will say, I'm certainly not one that believes that. I believe that as the students have expressed today, that this hybrid understanding, how digital tools are actually making us more efficient and more accurate in terms of diagnosis and outreach to patients. So overall, I will say excellent, well done. I have all my evaluations done as you were all presenting, and I'm very encouraged by your research, and I encourage you to continue. Digital health is in the embryonic stage, and there's so much that can be done, and I think you're well on your way, and I hope that you will continue to engage with the ISfTEH. There are a number of experts in the field that are members of the ISfTEH. So if you are interested in continuing in whatever areas of interest you may have, I'm sure there's someone under our umbrella who can assist you, help you, guide you. So excellent overall. And unfortunately, I have to move on to another meeting, but I thank you all for your contributions. Well done. Excellent.
Thank you very much, Michelle, for being here with us and for your support as usual. Thank you so much. And I'd like to invite Cherise for a few comments and words. Please, Cherise.
Yeah,
Good
thank
to
you so
see
very
you.
much. Good to see you. This was excellent. This was really good to see what's happening in the field, to see the combinations of the different technologies, methodologies. And I see in the presentation a strong push to help the community, to help everyone through these different methodologies. And I also learned a lot. And I am really grateful. And hopefully, everyone keep participating in the ISfTEH. We really, really want to have you all. And I look forward to hearing from you in the future. Thank you.
Thank you very much, Aris, for your words and for being here. Thank you very much. And Osama is with us. Please, Osama. Now, we'd like
Hello, hi, how
to
are
hear
you? Sorry, I couldn't
you.
use my camera. I really
No
enjoyed this hour.
problem.
Can you hear me?
Yes, yes.
I really enjoyed this hour of education. It was really inspiring to see those young researchers sharing with us their experience and their innovative ideas around education in general and how this can be mapped to our mission in ISfTeH. And I believe that they will have a very bright future by just focusing more and more on this topic. I believe that this also will help them in their future career for sure. As Michelle mentioned, it would be a great opportunity also for them to engage more with ISfTeH activities and events, so they can get connected to experts from different fields and missions and specialties in healthcare. I think the future is very bright. I was really, really impressed by all those presentations. It will be a very difficult mission for us to select the best three. Thank you very much.
It's true. Thank you, Osama. Well, thank you all. Congratulations again. Was a very inspiring session and a lot of outstanding work presented here today. Thank you to our jury for all the insights. And a warm thanks for Frederick, as well for all the audience who joined us today from all around the world. And now we looking forward to seeing you again in September for the final award session and to celebrating together the future and the new generations of leaders in telemedicine and digital health. Thank you. Have a nice weekend. Take care and see you in September. Thank you. Bye-bye.